Bismillah ar-Rahman ar-Rahim. At first, I want to express my great thanks to the organizing committee for the kind invitation for this upgraded and successful conference. I have the honor to introduce the next speaker, Professor Kevelkim Goshinye, Gezi University, Turkey. The talk will be Update in Neuroprotection Therapy in Neonatal Hypoxic Ischemic Encephalopathy.
Hi, everyone. First of all, I would like to thank you, the organizing committee, and especially Dr. Leo for his hospitality and inviting me to have this speech here. Today, we are going to talk about the update in neuroprotective therapy in neonatal hypoxic ischemic encephalopathy. Neonatal mortality constitutes about 45% of all childhood deaths. The most common contributor to early neonatal mortality is birth asphyxia. 4 million newborns experience birth asphyxia each year, 1 million deaths, and 42 million disability, cerebral palsy, epilepsy, mental retardation, and sensory deficits. Well, what is the current standard care in neonatal encephalopathy? Any high pregnancy risks for neonatal complications should be delivered at a tertiary center with trained and experienced resuscitators. The infant is evaluated for hypothermia, which should start within 6 hours of birth for infants with hypoxic ischemic encephalopathy grade 2 and 3. Management of seizures, fluid balance, hematological and cardiovascular abnormalities is essential for optimal outcomes. A multidisciplinary team concerning pediatric neurologists, cardiologists, other subspecialties, as well as institutional capacities for long-term EEG, MRI, physical and occupational therapies are also needed. But briefly going over the physiopathology, first, acute insult happens with hypoxia, and primary energy failure we are faced with. Then you resuscitate the baby, and we go to the latent period, which lasts between 6 and 15 hours. And then the injury ensures and goes on. The secondary phase lasts hours and days. After that, we go on to the tertiary phase, which lasts between months and even years. Therapeutic hypothermia is the only effective therapy for neonatal encephalopathy when hypoxic ischemic origin is high. A Cochrane meta-analysis showed that reduced death or major neurodevelopmental disability in survivors from 61% in normoterm in infants compared with 46% in infants treated with hypothermia. Death decreased from 34% to 25%, and disability reduced from 25% to 19%. These neuroprotective effects of hypothermia persisted even at 6 to 7 years. What about the knowledge gaps in hypothermia? 46% of infants has outcome of death or disability even after hypothermia treatment. Will there be any clinical trials designed to improve the hypothermia regimen? Or will there be clinical trials and observational studies that address extending hypothermia to infants not enrolled in the first series of hypothermia trials? Since injury is not only confined to the early hours following hypoxic ischemia, but extends to days following the insult, there is a rationale for further investigations. NICHD and NRI conducted an optimizing cooling trial. They looked if longer cooling 120 hours, deeper cooling to 32 degrees centigrade, or both initiated less than 6 hours of age is superior to cooling at the classical one, 33.5 degrees for 72 hours, among infants of at least 36 gestational age with moderate or severe HIE. What happened? They saw that longer cooling was not superior to 72 hours of cooling, and deeper cooling was not superior to cooling to 33.5 degrees centigrade. Well, so we stay in the same protocols as it is. How late can hypothermia be initiated? Given the knowledge gap concerning initiation of hypothermia beyond 6 hours, again, NRI made a randomized trial to see the benefit or harm from late initiation of hypothermia. Infants greater than 36 weeks of gestational age with HIE 2 and 3 assessed between 6 and 24 hours of age and then randomly assigned to an esophageal temperature of 33.5 degrees maintained for 96 hours, compared with an esophageal temperature of 37 degrees to determine the risk, death, or disability at 18 months. Enrollment has been completed, and publications of the results is pending. Well, should infants with mild hypoxic ischemia receive hypothermia? Before we knew that the children with mild HIE without CP have had normal outcomes. But however, the results said that those patients had lower mean IQ scores than controls. 40 children with mild HIE, when assessed at 9 and 10 years, when compared to controls, had more social problems, more anxieties, depression, attention regulation, and thought problems. And also, moreover, reports of initial hypothermia trials show that some HIE-1 infants not provided hypothermia had adverse short-term outcomes, seizures, feeding difficulties, abnormal MRI scans. So, some centers started to provide therapeutic hypothermia for infants with mild HIE, despite the absence of clinical trials to provide the evidence of benefit or harm from this therapy. Recently, a cohort from Ireland evaluated cognitive functions at 5 years among infants with HIE-1. 22 out of 47 children with HIE-1 had lower cognitive outcome than control infants for full IQ scale, and verbal IQ and performance IQ were both lower also. This finding also supported a randomized trial of therapeutic hypothermia for mild HIE to determine if cognitive function can be improved. Two randomized trials have started in the US and UK to address this issue. Well, should hypothermia be used in preterm babies? There is the absence of definitive data on neuropathology of HIE in moderate or late preterm. Do the data resemble those of a term infant? Is pathology dominated by selective neuronal necrosis, followed by parasagittal cerebral injury, and at least commonly focal ischemic necrosis, as in term babies? Or do the data resemble those of white matter injury and arrest of the oligodendrocyte lineage, which is the major hypoxic ischemic lesion in extremely preterm infants? In 31 preterm infants and 32 term infants with HIE who had therapeutic hypothermia and compared for safety and short-term outcomes, preterms had more adverse events. Intracranial hemorrhage occurred only in preterms. So they show that the safety profile of hypothermia in preterms differ from term babies in whom it is well tolerated. So NRI has started a randomized trial in preterm babies to see what's going to happen. Well, lastly, is therapeutic hypothermia neuroprotective when used in low and middle income countries? 7 trials, including 567 infants, were included in a meta-analysis, which is a poor quality meta-analysis. Most infants had no mechanical ventilation, cooling devices varied, cooling caps, gels, ice water bottles were used, and cooling therapy was not associated with a reduction in neonatal mortality. Only 3 trials reported neurodevelopmental outcome. Follow-up rates were poor, confidence intervals of reported outcomes were wide, imported clinical differences could not be excluded. So, a larger, a better designed, randomized controlled trials of hypothermia are underway in low-middle income countries. From here now, I've just discussed with you what is new in hypothermia treatment. From now on, we are going to see about the other therapeutic modalities. Hypothermia is beneficial in neonates with HIE to decrease mortality or major disability, but this benefit effect is very small. Reduction is from 46% from 61%. Only there is 15% absolute reduction. Thus, to increase this absolute reduction, what we can do in those patients? Do we have something to do while we are doing the resuscitation? Optimizing placental transfusion, either by delayed cord clamping or cord milking, impart a neuroprotective effect besides improving hemodynamics. Term infants who underwent delayed cord clamping had 45% higher mean ferritin concentrations at 4 months of age. Iron plays an important role in brain maturation and myelination, suggesting a neuroprotective effect of placental transfusion. Umbilical stem cells are being evaluated for the treatment of HIE. Providing an optimal placental transfusion ensures that the compromised infant receives the entire complement of stem cells, so it might work. Remote ischemic post-conditioning. When we talk about remote ischemic post-conditioning, it means the delivery of sublethal small ischemic insults removed from the area of injury that activate endogenous repair pathways to reducing extent of ischemic injury. Delayed RPCF improved long-term sensory motor deficits in a neonatal HIE rat model. Also, in a piglet model, RIPC showed a beneficial effect by modulation of nitrosative stress despite glial activation. Due to ease of application, it can be used in low resource settings as an adjunct to hypothermia and also a primary therapy in infants with mild HIE not undergoing cooling. Safety and efficacy needs further evaluation. When coming to erythropoietin EPO, its neuroprotective role has been recognized and evaluated in preclinical and clinical studies. EPO receptors are widely expressed throughout the central nervous system in several cell types, including progenitor cells, astrocytes, oligodendrocytes, and microglia. Erythropoietin has both acute and long-term neuroprotective effects. To date, 3 major studies, have evaluated EPO use in term infants with encephalopathy not treated with hypothermia. One showed either EPO of 300 units per kilogram or 500 units per kilogram or every other day for 2 weeks, starting within 48 hours of birth, or conventional treatment. EPO group had significantly lower rates for death or moderate to severe disability than in control infants. The other study examined the safety and efficacy of high doses of subcutaneous EPO, and the dose EPO group had also improved EEG background at 2 weeks with fewer delays on the Denver Developing Screening Test at 6 months, although MRI findings did not differ. Another study took 70 neonates with HIE 2 and 3 and gave EPO intravenously 200 units per kilogram 3 times weekly for 2 or 4 weeks, or standard care. At 6 months follow-up, the percent of MID and PEDIA indices of the Baileys were significantly higher in the EPO group than the control groups. EPO as a complement to cooling therapy, phase 1 trial looked for the effective dose and safety. High dose of 1,000 units per kilogram achieved levels to provide maximal neuroprotection with minimal risk with hypothermia treatment. Phase 2 double-blind placebo-controlled trial in infants undergoing therapeutic hypothermia for HIE, multiple doses of EPO, 1,000 units, resulted in less MRI brain injury and potential for improved short-term motor outcomes. And finally, a phase 3 trial evaluating the effect of EPO with hypothermia is coming. What about erythropoietin analog? Darbepoetin is a long-acting EPO analog that offers the additional benefit of once-weekly administration. A randomized trial evaluating the dose of Darbe as an adjunctive therapy to hypothermia in the first 12 hours of life and repeated at 1 week of life showed a good safety profile. So, a randomized trial is looking for the effects of EPO. What about xenon? It inhibits NMDA signaling, reducing acute cell injury. TOBY-X trial in 92 neonates concluded that xenon is unlikely to enhance the neuroprotective effects of cooling after HIE. It's expensive and requires a specialized delivery system. Alternative therapies are currently being evaluated. What about allopurinol? It is a xanthine oxidase inhibitor investigated as a potential agent for use in the treatment of HIE. Preclinical studies of HIE showed neuroprotective effects either used alone or as a complement to hypothermia. Follow-up of 2 performed randomized controlled trials at 4 and 8 years showed a neuroprotective effect of neonatal allopurinol treatment in HIE to infants. However, Cochrane review in 2012 did not reveal any statistically significant difference in the risk of death or severe neurodevelopmental disability. What about melatonin? It plays a role in normal glia development, has anti-apoptotic, anti-inflammatory, and antioxidant effects. Randomized control trials melatonin plus hypothermia, when compared to controls, revealed that melatonin plus hypothermia group had fewer seizures, less white matter injury on MRI, lower mortality rate without developmental or neurological abnormalities. It has a good safety profile with low risk for toxicity, is promised in management of infants with HIE, but larger randomized control studies are needed. What about magnesium sulfate? It is also an NMDA antagonist, reduces exotoxic damage after HIE. A prospective longitudinal placebo-controlled trial of magnesium sulfate used in infants with severe asphyxia without hypothermia revealed encouraging short-term outcomes. Due to its low cost and ease of delivery, magnesium sulfate is thought to be a potentially viable therapy in low-resource settings. What about stem cells? Preclinical studies have been done evaluating stem cells in neonatal brain injury. Unlike hypothermia, cell-based therapy provides a longer therapeutic window as repair and regeneration take place over longer periods of time. Cord blood stem cell therapy has protective effects on inflammation, apoptosis, oxidative stress, and may enhance regeneration. A meta-analysis of mesenchymal stem cells demonstrating a significant positive effect on neurobehavioral outcome following HI injury. In preterm model of global hypoxic injury, intravenous mesenchymal stem cell reduce cerebral inflammatory by induction of T-cell tolerance. A phase 1 trial evaluating umbilical cord blood cells to neonates with HIE showed that collection, preparation, and infusion of autologous volume and red blood cell reduced non-cryopreserved cord blood cells within first few postnatal days was feasible and relatively safe. 5 newborns, 4 with HIE2, 1 with severe HIE3, have undergone autologous umbilical cord blood cell therapy without any adverse effects of treatment with survival up to 1 year, a very promising therapy. Gangliosides. Monogangliosides therapy protects against apoptotic injury and attenuate brain injury. A meta-analysis of 10 trials consisting of 778 neonates showed that adjuvant treatment with monogangliosides improved short-term clinical effects and reduced long-term neurodevelopmental disabilities. However, limited information on optimal dosing, safety, and there is no long-term outcomes. Neonatal HIE combination therapies. For management of hypoxic ischemic encephalopathy, there is potential for combination of hypothermia and adjunctive therapies with agents that may affect the pathophysiological process at different phases. Melatonin, EPO, DARBI, xenon, topiramate are all being studied as adjuncts to hypothermia treatments. Stem cells and EPO have actions that extend into tertiary phase and may provide to be complementary to hypothermia treatment. Creative ways of combining pharmacological and cell-based therapies in secondary and tertiary phases of injury would be exciting and would especially benefit infants with HIE that evolved over time and missed the window of therapeutic hypothermia. Well, what about beyond the neonatal period? Do people stop? No, they go on studying. Activated microglia and macrophage phenotypes support neurogenesis and progenital self-proliferation are exciting candidates for repair and regeneration as they migrate to site of injury and generate trophic factors. Growth factors can prevent tertiary brain damage by attenuating inflammatory processes and promoting plasticity of the brain. Amphikines, small and diffusible growth factors that easily diffuse across blood-brain barrier, induce BDNF production in the brain when given systematically are being explored. Administration of macroNRAs to modulate microglial function and improve neural function long after injury is being explored as therapeutic agents. Well, future studies should focus on agents that influence pathological process other than hypothermia in order to improve neuroprotection. We have not a long way to go since the light at the end of the tunnel is shining. Thank you very much for your attention.
Thank you very much, Professor Kibelsim, for this interesting talk. Now we are going to questions. Anyone have question? No questions? Thank you very much. Thank you very much for you all for this attendance. Thank you, Professor, again. And now we can go to the dinner. Thank you very much.